All right, can I have everyone stand for the pledge? And Senator Bradley, would you lead us in the pledge?
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay, the one thing I will ask, if you're here for one of the later bills, if you could wait outside and we'll call you in as we're finished the bills so that we make sure we have seats for everyone who's waiting for the current bill. Because I will ask you not to get close to the door. So with that, I will open the hearing on House Bill 1168 and is the prime sponsor, Representative Staub. Welcome.
Folks, you can make seats available if you're here for the later bill. Everybody here for the first bill? Okay.
Thank you for hearing this bill. I have two handouts here. I emailed a link to the rest of you because my computer was my printer was misbehaving. We just couldn't get it right. So,
You can just leave it over there and we'll
Okay.
make sure there are copies being made for us. Thank you.
I did email everyone a link so you can look at it, but I will be referring to it. For the record, my name is Kathy Staub. I'm representative for Hillsborough 25, Manchester, Ward 5. And I'm here today to introduce House Bill 1168, which is a bill to establish a study committee to look at the impact of the housing crisis on people with disabilities. This is a companion bill to Senate Bill 408, and this bill, the House bill, came through the Special Committee on Housing with a 19-1 ought to pass as amended recommendation and pass the House on the consent agenda. The amendment clarified the entities that would be consulted by the committee and sets requirements for a minimum of 6 meetings and a report due on November 1st. And so those were the changes that were made in committee. I sponsored this bill at the request of advocates from the disability community. It's estimated that 1 in every 8 people in New Hampshire is living with a disability. Some people are born with disabilities, others acquire them during the course of their lifetime. And with the state's aging population, we will likely see that number increase. There are a number of areas that this committee could look at. One issue is that many people with disabilities relying on Social Security or supplemental security income for their income. And others are unable to work full time because of their disabilities. And all this leads to many people with disabilities having very low incomes. And that's the sheet that I gave you is from the National Low Income Housing Coalition. And it shows that if you're at or above 100% of area median income, for every 100 households of renters, there are 103 units of rental housing that would be available to you. As you move down to 50% of area median income, that number goes down to 66 units. And when you hit 30% of area median income, which most people on Social Security and SSI, that category they fall into, there's only 38 units for every 100 households that need a place to live. Looking at how to create more affordable units for people in that low income bracket is something that I think bears looking into. And the second area is appropriateness and accessibility. As people develop disabilities or if they are born with disabilities, people with physical disabilities need, accommodations. For mobility problems, blindness, etc. And then other folks with disabilities need to have, supportive housing so that they have access to services. And the last thing that I would like this committee to explore is ensuring that that housing for people with disabilities is distributed equitably around the state, because people should not be forced to leave their communities because they have a disability. So that's basically why I put in this bill. I'm happy to answer any questions that you have about it. There are a number of people from the disability community here that may have a more insightful and accurate assessment of, of what your concerns are. But I'm happy to answer any questions.
Thank you, Representative. Any questions from the committee? Senator Bradley.
So it was brought to my attention that the reporting on November 1 of 2024 might be premature.
Yes, Senator Ricciardi and I have, also had that discussion, that she felt that the timetable that was put out in the House bill might not be adequate for doing the kind of thorough investigation that she felt this issue warranted.
So you wouldn't have a problem necessarily if we moved it up by a year.
Pardon me?
So you wouldn't have a problem if we made it November of 25.
Oh, no, not at all. No, I'm a rookie, so I haven't been on a committee yet, so I don't know how they work. So yes, thank you.
One question. I know if we extend it out a year, a lot of times what happens is the first year we have a preliminary report and then the final report. Would you be agreeable to that?
Oh, absolutely, absolutely.
Thank you.
Yeah, I mean, the first report could be an examination of the scope of the issue and some best practices. And then the second part of it, we could look at potential legislation and rules changes that might enable more housing appropriate for people with disabilities to be developed.
Okay, any other questions from the committee? Seeing none? Thank you, Representative.
Thank you.
Representative Heidi Hamer? Hamer? Welcome.
All set? Hi, I'm Representative Heidi Hamer, Manchester, Ward 10, and a co-sponsor of House Bill 1168. Our 36-year-old son has a disability. We are his squeaky wheels. Our son has been living on his own apartment since 2012 with a furry four-legged roommate. Our son is a lucky one. There are many individuals with disabilities who are not able to live on their own due to availability of affordable housing. This committee, when formed, would be their squeaky wheel by working with state agencies, advocates, and members of the disability community to find a solution. I feel it's important we move this legislation along to help our disability community find affordable housing. We need to be their squeaky wheels. Thank you.
Thank you, Representative. Any questions from the committee? Seeing none.
Thank you.
Thank you. Lisa Bodwin? I'm going around.
You're going around. I thought I was going to be toward the end. Good afternoon. For the record, my name is Lisa Bodwin, Strategies for Disability Equity. I'm asking you to support HB 1168. Over the last 10 years of working with families and individuals living with disabilities, I've heard countless stories, countless nightmares from families who lay awake at night. You'll hear stories. I don't have to recount any for you. I'm also a parent. In my capacity as a disability policy professional, I co-authored a disability housing report in 2021 based on an informal survey of New Hampshire's disability community. It revealed that the severe crisis in workforce and affordable housing has had a disproportionate negative impact on individuals with disabilities, and in particular for individuals identified as having an intellectual or a developmental disability. I have several statistics in my testimony. I'll just give you a couple. 70% of both caretakers and individuals with disabilities reported a need for access to appropriately supportive, accessible, affordable housing. 68% reported that as family caretakers, their loved one is presently at risk of homelessness. 60% of caretakers reported their own age to be between 55 and 74. What this means is there is a tidal wave of housing needs on the doorstep of New Hampshire. Medicaid's home and community-based services waiver funding cannot be used for housing. New Hampshire's Department of Health and Human Services and the nonprofit service provider system inappropriately relies on parents to provide housing for their adult children. Parents age, they experience illness, and they eventually die. This is a serious, deep structural flaw in the current system, and it ignores the lifespan threat of housing instability and homelessness for individuals living with, in particular, intellectual and developmental disabilities. So it's functionally not stable. New Hampshire can't ignore this any longer. As lawmakers, you all need to understand the constellation of factors, including parents are already carrying the vast load of responsibility. There are statutory components to this issue, regulatory funding, and of course the workforce shortage. It's really important that New Hampshire establish a list of priority actions that the legislature can take in its role as one of the stakeholders to solve this, so that people with disabilities can have inclusive, universally designed, appropriately supportive, accessible, affordable housing, because we all know people with disabilities ought to be in the middle of their communities, whether it's a rural location, Manchester, or the seacoast. This will help to create the roadmap that people with disabilities need to have homes to take their rightful place as Granite Staters. Thank you.
Thank you, Lisa. Any questions from the committee? Nope. Thank you. Maddie Mandelbaum? Welcome.
Committee members of the Senate Health and Human Services. My name is Maddie. I am 69 years old. I'm a single parent living alongside my son, who is 28 years old. He has a rare motor neuron condition, resulting in a progressive medical condition and learning challenges. When my husband passed away 5 years ago, suddenly and unexpectedly, the question of what will happen to my son when I die loomed over us. Last year, as I underwent surgery for an unruptured cranial aneurysm, this question became more daunting as I struggled with the idea that I may not come out of the surgery alive or capable of caring for my son any longer. Family and friends often remark about the stress I am under caring for my son's needs. Only recently has it become so clear to me that it is not being able to address the question where Jeremy will live when either I die or can no longer take care of him that is the greatest stressor I live with. I awaken to this every day and carry it around with fear. My son came up with a plan for his future as he was getting ready to graduate from high school at 21 years of age. He has continued to hang on tightly to his plan of moving to Los Angeles to work for Hasbro and to create My Little Pony episodes. It is when he approaches me with a date and a plan for a move that I know he is feeling especially despairing of ever leaving my home and having a life of his own. People with intellectual disability deserve to be able to look ahead and know where they may live outside of their parents' home and plan a future for themselves. They can only do this when the community they live in offers a housing option to them. As a family in these circumstances, I resent those who have never considered our families or other families' needs. Clearly, this is a state that has voted and cared far more about supporting its business and economy than its people. I am impressed that my son has come up with a plan for his future that he is able to consider when he is discouraged about the present. His plan isn't a viable one, as he cannot make this move without my help, and I have no interest in moving to California and finding all new resources to care for him. However, I use his plan to motivate him around moving out of our home to a residence in New Hampshire, not too far away, so that I can continue to be involved with and help care for his needs as I am able. To address my worry regarding our future, I have volunteered my time on the development team of Our Place, a residence in the making for IDD adults in Dover, New Hampshire. My son has attended activities with other potential residents and is beginning to develop a vision of life in this home. Although he isn't always on board with the idea of being a potential resident, he has said to me, "At least I know, Mom, you are not planning on my living with you forever." In conversations such as these, I am aware of how our young adults have always relied upon us parents to come up with the next step in their developmental process. When we have been able to guide and support a successful transition, it is satisfying for the entire family. But when the need to move out and live independently comes up, I am aware of an ache in my soul. I have let my son down by not having this next step planned and implemented. I watch my son living in my home at 28 years old and think about the time he has already lost in learning to live more independently and alongside his peers, making meaningful relationships that eventually take the place of us parents, so that when we die, they feel a sense of community and support to keep them going. Our IDD loved ones deserve a satisfying and meaningful future as our typical adults do. So please vote yes to studying the need for housing in New Hampshire for IDD adults.
Thank you, Maddie. Any questions from the committee? Seeing none, thank you. Creighton Ward?
Hi, good afternoon. I have written testimony as well. I'm here on behalf of Kristen Evans, who's the Director of Policy at ABLE New Hampshire. So as the policy, well, I'm talking as her, as the Policy Director for ABLE New Hampshire, a disability justice organization committed to advocating for the rights and well-being of people with disabilities, I urge you to support House Bill 1168, which seeks to establish a study committee to examine the impact of the housing crisis on individuals with disabilities. The housing crisis has disproportionately affected people with disabilities, exacerbating existing challenges and barriers they face in accessing safe, affordable, and accessible housing. According to the National Low Income Housing Coalition, only 26 out of every 100 extremely low-income renters with disabilities in the U.S. have access to affordable and available housing units. This is an alarming statistic which highlights the urgent need to address the systemic issues that contribute to housing instability among this vulnerable population. Additionally, a study conducted by the National Council on Disability found that people with disabilities are more likely to experience homelessness and housing instability compared to their non-disabled peers. Discriminatory practices, lack of accessible housing options, and inadequate support services further compound the challenges faced by individuals with disabilities in securing stable housing. HB 1168 presents a crucial opportunity to comprehensively examine the multifaceted impacts of the housing crisis on people with disabilities, and to develop targeted strategies and policies to address these issues effectively. By convening a study committee comprised of experts, stakeholders, and individuals with lived experience, we can gain valuable insights into the root causes of housing insecurity among people with disabilities and identify evidence-based solutions to mitigate these challenges. Ensuring access to safe, affordable, and accessible housing is not only a matter of social justice, but also a fundamental human right. By supporting HB 1168, you have the opportunity to advance the rights and dignity of people with disabilities in our communities and to foster a more inclusive and equitable society for all. Thank you for your attention to this critical issue, and I urge you to vote in favor of HB 1168.
Thank you very much. Any questions? Seeing none. Thank you.
Thank you.
How about we will plan on executing this as soon as everyone's finished testifying, if we can cut back on the testimony as an ought to pass. Oh, thank you. I have Lori McIntosh up next.
Super short.
Okay.
Okay. So I'm Lori McIntosh. I'm a resident of Dover. I have 2 adult sons with developmental disabilities. I've talked to you before, so you know my story. I am the chair of the board of Our Place, New Hampshire, which is trying to build housing. So I'm going to skip to the chase and just say, what do I need? I need help. We are a group of parents. I'm meeting with 4 other groups of parents throughout the state that are also doing the same thing. They're all in various stages of trying to build housing, and we need help. We need help sorting through the federal rules, the state rules, the zoning regulations. There's so many rules about people with developmental disabilities that conflict with each other. We have to sort out whether we need to be certified or licensed. It looks to me like unless New Hampshire suddenly develops a Department of Housing for Developmental Disabilities, it's going to be us parents doing this. And if we're doing this, we could use somebody at the state level who is helping us, who is coordinating all this information so that when a group of parents gets together, they can go to this person and say, where do we begin? Because the learning curve is just rough. It's taken us a long time to figure out where we're going, how to do it, how to satisfy all the different departments. So that's what I want. Thank you.
Thank you. Next up, I have Paul Desmond. Hi.
It's Phil Desmond.
I'm sorry.
It's
Phil
okay.
Desmond.
I'll answer to anything. So, good afternoon. My name is Phil Desmond. I live in Portsmouth, New Hampshire, along with my wife and my 32-year-old son. I'm here today just to ask your support of Bill 1168, and I'll just give you a quick overview. We have been my son's advocates since he was first diagnosed 30 years ago. It's something that a challenge that we accepted, and as a result of all the efforts that we put together with the teams and IEP meetings and all of this, luckily our son is very successful at this point. But with a diagnosis of autism, he enjoys his life, but he's not safe. So, he is particularly involved with Friends in Action, which is a social group for adults with developmental disabilities. He loves it, but my wife and I suddenly came up with this thought at the onset of COVID back in 2020. It was just so vivid to think, if we died tomorrow, what happens to our son? So that's all we're looking for, is to be able to come up with a solution. We are also involved with Our Place. So my wife is the treasurer. I'm involved in planning and doing fundraising. There's a lot of creative opportunities out there because I don't want to say this discrimination, but there's just such a difficult scenario out in the Seacoast where we are. This housing is at a premium, and we're coming up with a plan that can enable people with disabilities to live safely and have a supported, enjoyable life. And that's all everyone wants, is just to be happy and to be safe. So I'll leave it there. That's the shortest presentation I've ever given. So thank you.
Thank you so much. Any questions? Seeing none.
Okay.
Thank you. Vanessa Blaze.
I decided to pass on.
Okay. Tracy Long.
So, you might remember this really cute face. I'll show it to you again. This guy. He'd be here today, but he's working and he's at the Humane Society, doing his fair share as a volunteer. The only reason why I really wanted to come up is when Lori mentioned about parents getting together, creating this housing, because we don't have a Department of Disability doing that. It reminded me that why? So either way, I'm very hopeful that you will remember Andrew in our situation where he's worried. He asked me last night, Mom, I'm going to be 31. Will I have a place by 35? And I said, well, I'm hoping so. So thank you.
Thank you very much. Tracy. Sam Hawkins.
I'll hand in my written testimony. I appreciate the committee's support.
Okay. We have an additional sheet. Karen Ouellette. Okay. Heather Stockwell.
Good afternoon.
Afternoon.
Thank you for taking a few minutes to let me come in. I am unable to stand for long periods of time without my feet getting numb, and so I've been waiting in the hallway. My name's Heather Stockwell, and I live in Dublin, New Hampshire, and I've lived in the state for over 50 years. And I support HB 1168. As we know, I'm sure you've all been talking about it this morning, that we have a housing shortage, and we've had that for some time now. And people with disabilities in our state are being negatively impacted because of this shortage. The number of seniors also in the state continues to rise and is currently reported to be at approximately 20% of our population. And I'm going to come back to that number in a few minutes. Much of our housing stock also consists of older homes, some over 200 years old. As people approach their older age, they may need to move because their current home has become inaccessible for them. They might need a single-story home without staircases or wider doorways, or bathrooms with a walk-in shower, lower countertops, because they are now using a mobility device. And as an emerging elder, I'm very familiar with this. I'm also learning that the senior population is more likely to develop a disability as they age. And I know this on a very personal level. I was already living with multiple dynamic disabilities, and dynamic disabilities are generally disabilities that you can't see, but they exist nonetheless. And my mobility and my vision and other things are starting to deteriorate. And so I'm acquiring new disabilities now. And I want to come back to those statistics, because in New Hampshire, we have 12.6% of the population that identifies as having a disability, and nationwide, it's 13%. So not a lot of difference there. But what was, in my research, what was extremely impactful for me to learn is that people between the age of 65 and 74, that number pretty much doubles to 24%. And at 75, it almost doubles again to 46%. I will also add that I think those numbers are probably even higher because a lot of people don't identify as having a disability because of the stigma that comes along with that. For instance, I'm looking around this room and some people are wearing glasses or corrective lenses. And I'd bet that probably a lot of people wearing glasses, depending on what kind of vision dysfunction they are struggling with, may not identify as having a disability. But that disability could affect your life a lot. If you can't see, you may not be able to drive, you may not be able to do some daily tasks that you once were able to. With that said, many elderly people and people living with disabilities may also be living on a fixed income. Even with the latest Social Security updates, it's still not enough to compete with today's prices, whether it's a rental or purchase. This is in part caused by the calculation being based on out-of-date cost of living scales, but also due to our record inflation numbers we've seen over the last several years, making it much more difficult for regular working everyday people to just survive. We need a new approach. We need new and renovated buildings that are overall more accessible. And I believe we need to be creative in that approach and to use a variety of tactics to get there, because it's not going to happen with just one tactic. A couple of the tactics that I am thinking about are seeking federal funds to help build more accessible housing that's also affordable, to be more flexible with zoning laws in our cities and towns. Section 8 reforms, for instance, having a housing directory and incentives for landlords to accept Section 8 housing vouchers. Also, I've talked to a lot of people who are struggling with their housing as well as healthcare. That is my regular day job. And plain language is something that we talk about a lot. Some of the forms and things that people have to fill out are not very understandable. And even as a well-educated person, I struggle sometimes to understand some of the forms when I'm being asked questions or looking over things for people. So I urge the committee to support this bill and to help find solutions for our growing housing crisis. Because for me, I have lived here over 50 years and I am actually thinking about leaving this state because of the very low stock of availability that we have that is even within my price range. So I thank you for your time, and I would take any questions if people have them.
Thank you. Any questions from the committee? Seeing none.
Thank you so
Thank you.
much.
Is there anyone here that would like to speak on 1168 that wasn't given the opportunity but would like to? With that, I will close the hearing on 1168. And do I hear a motion to go into exec?
So moved.
Senator Prentice moves exec. Senator Bradley seconds.
Move on to pass on this bill and suggest a committee amendment.
With the,
Yeah, on
per-
line 1 of page 2, just change the date to 2025, so it'll be a 2-year reporting.
and requiring a preliminary report on
Yeah,
November 1st, 2024. You okay? Yes. Sorry. All right. All right. So we have the committee amendment with the changes. All those in favor of the committee amendment on 1168, say aye.
aye.
Aye. Opposed? I move ought to pass as amended on 1168. Any discussion? Okay, second. All those, any discussion? All those in favor of ought to pass as amended on 1168, say aye.
Aye.
Opposed? So be it. I'll take it out. Thank you. I'm sorry. We need to move out of exec. I'll move out of exec. All those in favor say aye. Opposed? All right. Oops. All right, I will open the hearing on House Bill 1278 and invite the prime sponsor, Wendy Thomas. Welcome.
Thank you, members of the committee. For the record, I am Representative Wendy Thomas, and I represent the town of Merrimack. Today, we're here to talk about House Bill 1278, which is relative to qualifying medical conditions for the purpose of therapeutic cannabis. We keep identifying conditions that are allowed under the New Hampshire Therapeutic Cannabis Program. Since I've first worked as a rep, we've tackled insomnia, opioid usage, and anxiety. We keep adding new conditions as they become known. And how do they become known? We read and we talk to patients. They let us know what works. I'm a therapeutic cannabis patient. I started in the therapeutic program 5 years ago because of chronic pain. It was a car versus a bike accident when I was a kid. Since being in the program, I've also used cannabis for insomnia, eating issues, gut issues, PTSD, and anxiety. I found relief from all of these symptoms, some of which are not covered in the program. I talked to many, many people about therapeutic cannabis. They want to get into the program. They want to see if cannabis helps their condition. No one in the therapeutic program uses cannabis to feel, quote, high or inebriated. I spoke to a caretaker in Maine, and she shared with me a very wise truth. She said, if you're getting high on therapeutic cannabis, then you're using it wrong. However, the biggest concern I hear is, will I qualify because I don't fit the current patient model? These are all examples of cases that would not qualify, but which should, in my humble opinion, for the therapeutic cannabis program. One is, I'm having surgery, and I understand it will be painful for a few months. Cannabis can help with that. I have IBS, but not Crohn's or ulcerative colitis disease. Cannabis can help with that. I have long COVID. Cannabis can help. I have a procedure done regularly that gives me anxiety. In my case, that would be dental. I'm getting older. When I work out, I'm really sore the next day. And another complaint I hear all the time is I have serious period cramps. There are many, many women that use cannabis for menstrual cramps. So this bill would allow two avenues. It would allow a physician who is not familiar with the program to go through the list that is identified on the application and to check off what they feel the patient would qualify for. The other avenue would be for a physician who is cannabis literate. And we're hearing that a lot of physicians, are starting to take courses on therapeutic cannabis, especially with the descheduling from the government. And so those physicians have more awareness of conditions that would be helped by therapeutic cannabis. And so the point of this is that they would be allowed to refer a patient to the program for any condition that they think would fit and benefit the patient. The recent HHS report on descheduling cannabis identifies additional uses that cannabis has been found helpful for. These conditions include ALS, autism, muscle wasting, cancer, chronic pain, Crohn's disease, epilepsy or conditions causing seizures, glaucoma, HIV/AIDS, MS, Parkinson's disease, persistent severe muscle spasm, persistent severe nausea, PTSD, and spasticity. Chronically ill patients are not interested in being zoned out on the couch. We have had enough of that, and we want the coach to put us back into the game. So why are we potentially denying New Hampshire patients relief just because we haven't gotten around to getting their symptoms or condition into law or on a qualifying list? I understand that many physicians are not interested in anything about cannabis. However, there are many physicians who are willing to learn about how this plant can help their patients. They are willing to look at reports and read literature that gives new information about possible uses. And they are willing to let their patients try something different that has been demonstrated to work. I just want to also mention that the Medical Oversight Board voted 7-1 to support this bill. What we absolutely need to do is stop trying to practice medicine and let the physicians treat their patients as they see fit. I'm ready to take any questions if you have any.
Any questions from the committee? Representative, I do. Will this get rid of the list?
No, because, well, the list would stop. We wouldn't be putting any more conditions on the list.
Okay.
The reason it wouldn't get rid of the list is because there are some physicians that are cannabis naive, cannabis unaware, and so they need some sort of a list to give them the guidelines. So there would be, those are the two avenues. You'd have the physicians that are not aware of, specifically, they've heard cannabis works, you might have gotten reports from other patients, but they don't specifically know how to deal with it. So you'd have that avenue, or you'd have the other avenue, which a physician could say, all right, you've got long COVID gut disease, or not disease, or issues, which is something I had. I had long COVID and I had gut issues for about 1.5 years. So it wasn't Crohn's, it wasn't ulcerative colitis. It was a gut issue that was actually helped by cannabis because it stopped the cramping enough so that I could both eat food and retain food.
So if you're a physician that doesn't know the list, it'll be there. But if it's a physician that does know it, then any condition that they think would benefit, they would be able to do that.
Correct. So a physician who also has awareness, I mean, there's situations where you have situational anxiety. If you know you're going in for surgery, you're going to be anxious about that. There's going to be pain on the other side as well. And so a physician who is aware of that could refer a patient to the program to use for that condition. That's not listed on the list.
So that goes back to my question. If a doctor who isn't familiar with, has the list, and a doctor who does, the doctor who is familiar with therapeutic cannabis and can authorize it, but the doctor who's not familiar with it and is looking at the list doesn't know that, some of the other conditions can be used. How do you get the doctor that's not familiar and is only looking at the list?
There's a big push in that.
Former representative is going to answer.
Yeah.
Okay.
But the other thing is there is a push to deschedule or to reschedule cannabis to Schedule 3. Right. I would think that if I was a physician and I was treating patients with conditions that could be treated by cannabis, I would learn about it. I would read a book, read a couple books, and familiarize myself with it.
Okay. Thank you. Any other questions? Seeing none.
Thank you.
Representative Howard. Welcome.
Thank you, Senator. Thank you for having me today. My name is Representative Heath Howard. I represent Stratford 4, the towns of Stratford and Barrington. I'm a member of the Therapeutic Cannabis Program. And when I was first looking into joining the program, at the time, chronic pain patients had to be prescribed other medications before pursuing the route of therapeutic cannabis. And we've since made changes, luckily, but my situation and what I experienced, other people do as well, because they may have a condition that is not necessarily listed on the list of set conditions that we as a legislature has designated acceptable for being a member of the Therapeutic Cannabis Program. But in terms of having changes being made to that list, we have to come back here every single time we want to make a change. And this legislation would help eliminate that by giving doctors the say in who would be most beneficial in terms of their patients. So I think that this is the best way forward to eliminate a number of these hearings so that we can let doctors take care of their patients the best they can, and so that patients can get the care that best suits them. And especially with the opiate crisis going on right now, we definitely need to allow people to have alternatives. Thank you, and I'm open for any questions.
Any questions from the committee? Seeing none? Thank you.
Thank you.
Honorable Knurk. Representative.
Yes, thank you so much. For the record, Jerry Knurk, Chair of the Therapeutic Cannabis Medical Oversight Board. And I'll try to address some of these other questions that have come up as well. And yes, we did vote 7-1 to support this bill as written, and it passed the House on a voice vote. It just to simply quickly clarify to remember that, yeah, you can't prescribe this. It's a Schedule I drug. And so you have to be certified. To be certified, it's a somewhat cumbersome thing. You have to have a qualifying condition that exists in statute, both in terms of the condition and in terms of a symptom, which is an important issue. And then that statute confers protection upon the person who's using cannabis for their possession and use. Basically, 1278 offers an alternative process for certifying. It allows more provider discretion, but it does have safeguards in place, and that's a key issue. So without strictly following the statutory list, yes, the provider can say, gee, in my clinical opinion, I think this will be helpful for this person, and therefore I will certify them. Now, there's been discussion in the past about just getting rid of this list and making it simply at provider discretion from that's gone on for a few years. And indeed, the conversation that just went on about bills keep coming back, and I particularly spoke against that. Well, I spoke about it until like 2017, saying, is the legislature the right place to make these decisions, which actually led to the Therapeutic Cannabis Medical Oversight Board, which is one of the reasons I got roped into it. But in any case, the issue that we had initially was if we do this, a lot of providers just don't have enough knowledge to be able to decide what might and might not work. And so we were not ready to make that kind of a jump. One way to look at this is it really basically creates a two-tiered system for certification. So providers who do have, to address your question, a limited knowledge of the therapeutic use of cannabis can still use the standard approach. They consult the list of statutory conditions and symptoms, and they say, yeah, okay, they're on the list, so let's go ahead and certify them and give them a try. But the new tier is available for those providers who do have more knowledge, those who have delved into it, taken courses, understand a little bit better, and then they can make a decision as far as the risks and benefits of the therapeutic use of cannabis and make an informed decision about that with the patient. And that's really not that dissimilar to what providers do, particularly if they're doing off-label use of FDA drugs. You think about it, the FDA says, hey, this drug works for thus and such at this dose. It's okay to use. But there's a huge number of drugs we use off-label. It was not approved for something, but we found that it works for it. And so we keep it as that. You can't market off-label uses. There's all kinds of rules about that. But a huge number of drugs are used in an off-label fashion. So in a sense, the Therapeutic Cannabis Medical Oversight Board acts like the FDA, sort of. We review it and we say, yeah, there's enough evidence that this makes sense, not in evidence. We do not work anywhere near at the level of the FDA, but we... Huh? No, that's probably why we don't. Yeah, I mean, it is a real issue. So we do our best, and that's why we sometimes do come and go, nope, not enough evidence. But that doesn't mean it should never be done. But we don't want to say, hey, for the standard person out there, they can look at it and say, oh, yeah, that's there. Let's just sign them up. So I think that I somewhat disagree with what Representative Thomas said. We might still add conditions. In fact, the issue is if this passes, there would be some question as to what our role is. We still would supervise the medical aspects of it, and we might still look at conditions and be able to continue to maintain a list so that the person who doesn't have as much knowledge can refer to that, the provider, and also to get away from using the word physician, because remember, it is providers, APRNs, BAs, and physicians can all authorize people. The rescheduling also, if it just goes down to a Schedule of 3, it's still not approved unless the FDA approves it for something. And so there still is going to be an issue. If it gets descheduled, becomes like alcohol, then it's a moot point. But in fact, again, we don't know what would happen to various therapeutic cannabis programs and so on in such a case. But that's a whole different question, and that's perhaps a long ways off. Now, one thing to notice in lines 4 and 5, the word or is used in this standalone qualifying condition rather than the word and. And that's what's used in the statute for regular certification. Now, it's often difficult to clearly link a condition and a symptom in somebody, which is why we have that catch-all that you can have any other condition which has caused blah, blah, blah. That's kind of a little bit of a back door. Medical prescribing is often driven by symptoms. So you go in with a stuffy nose. We don't have to diagnose exactly why you got a stuffy nose. We can give you a decongestant. Or you have a pain. We give you a non-steroidal anti-inflammatory drug to use. We may not know exactly what the cause of that pain is, but it's a decent thing to try. So this will allow symptom-driven treatment for the qualifying group, which can be often helpful because the diagnosis may be more unclear than, for example, knowing what the symptoms are. And this bill does not change the use of the word "and" in the regular certification process. And again, the safeguards I mentioned. What are the safeguards? Number one, it's 21 years of age or older, and that's good because in kids, there are specific unique issues and problems we need to protect them, and that's why we have so few kids in the program. And so it should not be something that's willy-nilly done in kids. Limiting provider discretion to certifying debilitating or terminal medical conditions or symptoms also assures that it's going to be used for impactful conditions and symptoms, and that'll be good. So the bottom line is, for those who don't know a lot, they still have the old system they can rely on. For those who really know a lot, they can practice with a little bit more discretion. And I think that's a reasonable thing. And that's what the rest of almost everybody on TCMOB also felt. So we would prefer you would pass this, and I'll take any questions.
Any questions from the committee? You look questioning. You answered my question. Thank you. All right. See you.
I was scribbling up so that I could be ready.
That's all the speakers that we have. Is there anyone here that would like to speak? Oh, okay. Matt Simon?
Thank you, Madam Chair. For the record, Matt Simon. I work for Granite Leaf Cannabis. We are a nonprofit therapeutic alternative treatment center with dispensaries in Chichester and Merrimack, a production facility in Peterborough. We are solely focused on serving patients who are registered with the New Hampshire Therapeutic Cannabis Program. I'll be very brief. The previous speakers have made pretty much all the points I wanted to make. I just wanted to share some insight. As you may know, I was one of the people very involved with passing the therapeutic cannabis bill, worked on it from 2008 to 2013 when it passed. And I think the argument that held sway the most and the rhetoric that we heard from many legislators who voted for this was, if my doctor thinks I could benefit from cannabis, who is the state to stand in the way? So one of the specific policy disagreements that we had at the time was, should the bill actually be a recommendation where the doctor has to believe and certify that the patient, that in the doctor's opinion, the patient would be likely to benefit, that the benefits would likely outweigh the risks. And ultimately, it was determined that that language shouldn't be in the bill. We went with the certification model that's been described. Doctors were simply to indicate whether the individual has a qualifying condition or symptom, and it was not a recommendation. So I think this is an opportunity to live up to the rhetoric and the arguments that were used to pass HB 573 11 years ago and truly empower medical professionals to use their judgment. So I support the bill. Thank you.
Any questions from the committee? Seeing none, thank you. Dr. Joe Hannon? Welcome.
Feeling a little shorter here. Thank you. Good afternoon, and thank you for listening to me today. My name is Dr. Joe Hannon. I'm speaking in the hopes that you'll pass House Bill 1278. I was on the original Cannabis Study Commission back in 2018 that met very frequently and talked to every other state that had already legalized. I'm also on the advisory board for the New Hampshire Cannabis Association. I'm a retired foot and ankle surgeon and a person in long-term recovery from substance use. I'd like to start with one of my favorite jokes I used to tell when I was practicing. I would say, well, I've got good news and bad news. And they'd say, well, tell me the good news. And I'd say, well, they're going to name a disease after you. Unfortunately, now the punchline can be the bad news is your disease is on the list. So what are we going to do? Terminal illnesses, debilitating conditions, and symptoms that aren't covered would be covered under this bill. I didn't realize, and when you're young and healthy, you don't realize how bad some debilitating conditions can be. And then once you experiencing it, as we get older, you realize how life-changing it can be for someone. Over the summer, I had some back pain, and I realized that I got an MRI, and they said, "Oh, have you had any trauma?" I said, "I guess so, probably." And they said, "Well, you've got 3 healed back fractures that you broke sometime in your life." I'm like, "Wow, just broke 3 vertebrae, didn't know it over the years of doing stupid stuff." Couldn't walk, couldn't breathe. I could barely sleep for well over a month, almost 6 weeks. It took me about 6-7 months before I could even get back to my regular activity. And being someone in recovery, I was adamant about not doing any opiates. They were like, well, here's some Percocets for your pain. That way you can brush your teeth and comb your hair. I bought 4 pairs of sandals last summer just so I wouldn't have to tie my shoes. I'm not a sandal guy. It shouldn't get to the point where I'm forced to do that. Having a safer alternative, now I'm not crazy about the idea of using cannabis for long-term usage for someone who's in recovery, but it's a safer alternative. I have several friends who've had cancer in recovery or other serious conditions or injuries, and when they've had to use something and they've been told you have to use opiates because the pain is that bad, this was a very viable alternative. But for everyone, it's not always on the list. So I'm just saying that, as someone who did treat patients, someone who's seen this from every angle, from a legislator, from someone who's studied it as a substance, for a commission, and as someone who's been working with this as an advisor for many years in New Hampshire, I think there's no reason not to do it, to add this to the list and give doctors the discretion to do what they have for just about every other, actually not just about, every other drug on the planet. They can do what they want. I never once went to the RSAs and looked up what I can give to someone for foot fungus or a bad, ankle injury. It doesn't happen. Now, we heard that some people might come and say we need to check the list because we're not very educated on this yet. But the education is coming. The list will be obsolete in not too many years from now, I hope. But in the meantime, I think it's important to give patients the option for safer alternatives than opiates. It's going to be life-saving, life-changing for many people. And I just would beg you to please do this simple thing that leaves the doctors in charge of what their patients can handle. I'd be happy to take any questions.
Any questions from the committee?
Probably not. Okay, that's good.
Seeing none.
I appreciate it. Thank you.
Thank you. Right. Now, is there anyone that would like to speak that hasn't been given the opportunity? With that, I'll close the hearing on House Bill 1278. Okay, I am opening the hearing on House Bill 1231 and the prime sponsor, Representative, no? Representative Thomas, come on down.
Thank you. Thank you again. For the record, I'm Representative Wendy Thomas, and I represent the town of Merrimack. I've got some. You've heard this one before. It's come up several times. This bill, House Bill 1231, permits qualifying patients and designated caregivers to cultivate cannabis for therapeutic use. So, why do we need this bill? We have dispensaries in New Hampshire. One reason is the cost. Cannabis is not covered by insurance. If you are a patient who uses a lot to keep your symptoms under control, it can be expensive. And remember, this is a vulnerable population. Many of us are unable to hold jobs. House Bill 1231 helps low-income, immobile, or homebound patients who need medicinal cannabis to be able to grow their own medicine or get help doing so. Another reason is dispensary location. There are 7 dispensaries in all of New Hampshire. Not all patients have cars or an affordable way to get to them. Just to put that into perspective, we have 5 pharmacies in my town of Merrimack. Another reason to do this is strains. Everyone reacts differently to different cannabis strains. What may work for one person may not be as effective for another person. Sometimes the strain that works best for you might be discontinued. Growing would be a good option. I mentioned earlier that I had long COVID that hit my gut and I had severe gut dysfunction. Diesels and Cushes came to the rescue for that. In 2022, I was also diagnosed with cancer, and I've had 3 major cancer surgeries, and I have relied on cannabis to get through all of that. The New Hampshire Therapeutic Cannabis Program began in 2013. It is 10 years old. Actually, now it's 11 years old. Since it began, we have learned about the program and patients' needs. Dispensaries have been added along with more qualifications to get into the program, and the program has been modified to better suit patients' needs. Since 2009, the New Hampshire House has consistently supported bills allowing patients with qualifying medical conditions and their caregivers to cultivate a limited supply of cannabis. In 2012 and 2019, the Senate agreed, advancing home grow legislation to the governor's desk. Both bills were vetoed, and the override efforts fell short in the Senate. In 2020, the Senate passed a home grow bill in a voice vote, but the outbreak of COVID-19 prevented it from being considered in the House. So what does this bill do? This bill allows New Hampshire therapeutic cannabis patients or caregivers to grow their own cannabis plants at their place of residence within guardrails set forward by the bill. Patients are still bound by the guidelines of the program as identified when you submit or renew your application. If the plants are grown outside, the plants cannot be viewed from another private property. It would allow New Hampshire therapeutic cannabis patients to have and grow 3 mature flowering plants, 3 immature non-flowering plants, and 12 seedlings. Patients can grow the plants from seeds or clones, and some of the dispensaries have said that they will be able to provide seedlings. The plants must be kept in a locked and secured location that is reported to the state. The patient must ensure that the plants are secure from unauthorized access. Patients would have access to state labs for testing of cannabinoids and possible contamination, which most likely would be mold. What this bill does not do, this bill does not mean that every therapeutic cannabis patient will start growing plants. Some patients will try and then realize it's too much work and they'll stop. Some patients will be interested and will simply gather information on how to grow cannabis plants. And some patients will simply say, I'd rather buy the flower. HB 1231 does not create dealers or suppliers. The therapeutic cannabis program is self-regulating. To be in the program, you must sign a contract that stipulates limitations on how much cannabis we can have, where we keep it, and where we can use it. We know that if we disregard these conditions, we can be kicked out of the program or we can be penalized at a higher rate than others. No patient is going to risk that. Again, this is not recreation. This is a medical program used for very sick patients. It does not create hidden stashes of cannabis. Growth locations must be reported to the state. So some reasons for allowing home cultivation. Secure home cultivation is not causing any problems. 14 of the 18 states that have legalized adult use cannabis and about half of the medical cannabis states allow for personal cultivation. In the states that have reasonable safeguards, home cultivation has not been a problem. No state has repealed home cultivation. Home cultivation is important for patients. About 6% of Americans use cannabis for therapeutic reasons. Insurance does not cover that. For many patients with serious medical conditions, medical expenses and a reduced ability to work make getting cannabis difficult. By allowing home cultivation, you are giving the therapeutic patients financial relief for their non-insurance covered medicine. Home cultivation helps to displace the illicit market. Some patients need more. Some patients don't have the financial means to purchase tested and measured cannabis from the dispensaries. Home cultivation would allow these patients access to cannabis without having to use the illicit market. Home cultivation is consistent with our commitment to freedom and equality. In a free society, in a state with the motto of free live or die, adults should be allowed to grow cannabis plants in their home for therapeutic use. What's happening in some of the other states? In Connecticut, you're allowed up to 3 mature plants and 3 immature plants. In Maine, you're allowed up to 6 flowering plants, 12 immature plants, and unlimited seedlings. Massachusetts is up to 12 plants per patient or person, no more than 12. Rhode Island, up to 12 mature plants and 12 immature plants. Vermont, up to 2 mature plants and 7 immature plants per patient. So who supports this bill? This is a bipartisan bill that originally came out of the House and is supported by the Cannabis Board, the Therapeutic Cannabis Board that voted unanimously to support this bill. The dispensaries also support it, and they are ready to roll out educational classes on how to grow and can even offer equipment that is needed to grow. I just wanted a point that keeps getting raised is the police have some concerns about whether or not if they see cannabis or something, whether or not somebody is a patient, how are they going to be able to figure that out? I'm given a driver's license when I pass my driving test, which allows me to drive a car. To be in the therapeutic cannabis program, this is my therapeutic cannabis card. It identifies me as a patient. If a police officer comes up to my house and says, are you growing plants? And I say yes, and then I can show them the card. This allows me to grow the plants. In summary, the New Hampshire Therapeutic Program has been alive and well since 2013, and it is only getting stronger as we listen to patients' needs. House Bill 1231 is a compassionate, humane bill that also encourages business growth. It's time to let patients take more control of their health and their wallets by allowing for home growth in the therapeutic program. I'm happy to take any questions.
Okay, thank you, Representative.
My pleasure.
Jerry Knirk.
And again, for the record, Jerry Knirk, Chair of the Therapeutic Cannabis Medical Oversight Board. Indeed, we do support, the board does support HB 1231 to allow home cultivation by therapeutic cannabis patients and designated caregivers. The reason is because we think it will help with the affordability, accessibility, and availability of specific strains. Again, this is a retread of 431 from 2023, which passed the House on consent and died on the table in the Senate. This year, 1231 passed the House 294 to 66. 2 years ago, TCMOB held a listening session for feedback from patients about the program. And the most common concerns that we heard in that feedback session were issues of affordability of products, accessibility of ATCs, and availability of a specific strain, which may not be available in their nearest ATC, but which is needed by the patient to treat their specific symptoms. The reason about that is different cannabis strains have different cannabinoid and terpene profiles. The terpene are the things that kind of give any vegetable a smell. I mean, you handle your tomato plant, you know you're working on a tomato plant. That's a terpene. So the terpenes and the cannabinoids, and they interact in what's called an entourage effect to have the effect upon the symptoms. And different strains will have different effects for different people. Several patients who were at that listening session felt that home cultivation would solve these problems or at least partially address them. So at the January 2023 meeting, TCMOB reviewed the issue, voted unanimously, agreed with the concept of home cultivation. Then we revisited it in October 2023 with the new bill and agreed to continue our support of the bill. Now, we also then responded to the fact that there were some concerns that were raised, particularly in the House last year, that home cultivation would diminish the knowledge of the cannabinoid content of home cultivated cannabis compared with the products available, which is true. You go to the ATC, you get a nice labeled product. But although we agree that's certainly an issue and a potential, we note that the bill does allow a home cultivator to be able to submit their cannabis to a lab for testing. It does give them affirmative defense for transporting it to be tested. It gives the ATC affirmative defense to be able to test it as well. Not ATC, I'm sorry, the lab. This will allow them to know their cannabinoid profile and the concentration and ensure safety with respect to contaminants. Now, not everybody will do that, but if they wish to, they can. The bill also allows ATCs to provide seedlings with known relative cannabinoid content. That means, for example, the ratio of CBD to THC and all the other multi-letter acronyms. And that will give them the help to get a strain that they think is going to be the one that they need for their particular condition. And likewise, actually, seeds for cannabis are federally legal and they're available with specific targeted cannabinoid content. Obviously, growth will change it a little bit. The bill does have robust protections with respect to limitations in the number of cannabis plants that can be cultivated, the registration of cannabis cultivation sites. They must be enclosed and locked. So those protections will make the home cultivation safe, secure, controlled, and should satisfy the concerns of law enforcement. Now, the amendment, just to clarify what goes on with that, that corrected two errors. One was just purely a grammatical error. One was a wrong date, 2024 instead of 2023. And it also, though, did remove an affirmative defense that existed in Section 14 on pages 4 and 5 of the original version. That allowed an affirmative defense for patients who had applied for a card but not yet received it. I testified against that in the House because they can just wait that short time till they get their card. They did amend that out. That is all set. So the amendment does not change anything. It makes it actually a better bill. So we urge you to pass 1231 to allow home cultivation by caregivers and cannabis patients, to allow an improved affordability, accessibility, and the availability of specific strains a person may need. And I'll be glad to take any questions.
Any questions from the committee? Seeing none?
All right. Thank you very much.
Oh, did you have one? Sure. Okay. Michael Bison? Bison? Bison.
Yep. So, my name is Michael Bisson. I'm from Franklin, and I'm here today to talk about costs. And I know people have discussed a little bit, but I think we need to put some numbers on it so that it makes a little more sense. Okay, most people who have chronic pain conditions, they're taking incredibly strong medications, taking oxycodones, or they may be taking the Contin, the extended release. They may be taking morphine sulfate. They're taking real medication. Cannabis is only moderately effective. So you're asking them to switch from extremely strong medications to only a moderate painkiller. And what you're finding is that if you're on the cannabis, you're not going to get pills too. And that's a fact. No doctor is going to say, oh, here's your codeine and go get a joint. It's not going to happen. So it's either or. So what happens is, in order to have the ore, you need product. If you're unfamiliar with how the product is made, once the plant has been cured, it is dissected 7 times before I buy the flower. And so many of the good attributes of that plant that I could use in my home, I can't juice a raw plant because I don't have access to it. Many people love to juice, but I can't do that because I don't have access to a raw plant. I don't have access to the roots, none of it. When the dispensary makes gummies, they make shatter, they make hash, they make all these other products that you may or may not be familiar with that are concentrates. They had to get that concentrate by working the raw product, and then they sell me the leftover raw product. So it's already been handled between 4 and 7 times. If I'm growing it at home, I'm getting the whole thing. I'd be able to juice it. I'd be able to make everything I need on my own, and I would have all parts of the plant. I wouldn't just be buying a cured, dried bud that's already been keefed off and half the product is not there. The second thing that I run into all the time when it comes to the cost is that people who are on SSI, they live on under $1,000 a month. They are not going to the dispensary, period. They don't have money to walk in that door. If you're living on a simple SSDI check or a regular retirement check and you are not working, you're still not walking in that door because you still don't have the money. I happen to live on a disability check. I broke my neck in 11 places and it is fused down to the middle of my back. I am able somehow to still work, so that allows me to at least continue to own my home in Franklin and go to the dispensary a little bit. And we're talking about 1 gram of plant material a day. That's it. Now, a joint at their dispensary is about 1/2 to 3/4 of a gram. It costs $10. So I'm basically having less than that in the morning, and then what's left at night. That's it. That's all you get. You don't get any in the afternoon if you twisted your knee and you really need to lay down and you're hurting. No, there isn't any. And that's a problem. When I first moved back here from California, I grew up in the state. I grew up here 25 years. My family owned a business right here in Concord for 54 years. And one of the reasons that I came back is because the program was here. I didn't have to live in California anymore. I can go home finally. But what I discovered when I got here was that there was no provision to actually help people be able to afford it. You walk into a dispensary with $350 for an ounce, and you're going to turn around and walk right out the door. What are you going to do with that? 1 ounce of product is 1 gram a day. That's it. So if you want to, and to give it perspective, the federal patients receive 300 joints a month. They have breakfast, lunch, dinner, breakfast, lunch, dinner, snack, afternoon snack, nighttime snack, right before bed, wake up at midnight and have some more. That's what those people get. I'm never going to get that. If I'm lucky, I'm going to have a joint in the morning, have a joint at night, and that is it, because the funding is not there. If you live in a federal subsidized housing, you definitely don't have any cash to go walk into a dispensary. We are talking about helping people who are never going to get in the program. Because what would be the point? They have a card, they can't use it. Oh, their friend gave them some medicine. That's great. So they have medicine today, but not tomorrow. How does that create a serum level for therapeutic use? It does not. So I'm asking for some consistency for people who are stuck at home. They're going to be able to put some time and effort into cultivating their medicine. They're going to have a live plant they can juice. They're going to be able to make their products at home. That's what we're looking for. And I appreciate your time. Thank you so much.
Thank you. Senator Prentice.
One quick question.
Yes.
Thank you for taking my question. What do you mean by juice?
Well, no, if I'm sure you might have heard from the 50s, the old Vitamix, you had a juicer where you would just ram everything in there and out of the bottom came a liquid and you would just drink it.
Okay.
I can't do that because I don't have the plant. Now, I juice plenty. Everybody loves to have their asparagus, carrot, thing, whatever they make in the morning. Everybody likes their juice, whatever it is. Some people are just, give me the orange juice from the bottle. But we're talking about a therapeutic plant that if I had access to the unaltered raw plant, it is completely different than a cured plant. A live plant which I'm sure you're familiar with, as some people tell you as a vegetarian, to cooked vegetables. There's just more there to work with. When you're eating an alive plant, you're getting a higher level of benefit from it. And so, you know, for many people, it was simply being able to use every little bit of the product. I can put the stems in there and juice them too. I can throw the roots in there. I can put it all in there. And so now, instead of just being stuck with half a gram to puff on, I can have juice. I can make my own butter to cook with. I can make my own gummies. And when you handle it and the parts fall on the table, you can press them into and make some concentrates if you'd like. But until you have a plant, you don't have access to that. All you have is dried product. And due to cost, you're not going to go in and buy gummies or anything like that. My final statement would be, Granite Leaf did one thing for the really poor people that they are now, I'm told, no longer able to do. They used to take the floor samples that were dried out from everybody looking at them for the last 2 weeks. They would repackage them and sell them to the people who had no money. And I was told that was shut off. So I don't even have any reason to go into the dispensary anymore at this point, because that was the only way I was able to afford it. They were taking a $350 cannabis monthly bill down to $160, which made it affordable. Okay. And now it's simply not going to be that way anymore. I know they have limitations. They're going to try, but they have a price point. They have a structure. They can't give it away for free. Okay. And I understand their position. So.
Thank you.
Thank you.
Sorry. Next up, Ted Wright.
Right, but you don't get inebriated.
Good afternoon.
Good afternoon.
Thanks for letting me speak. My name is Ted Wright. I'm a former state rep here in New Hampshire. I was actually one of the sponsors of HB 573 in 2013. Well, I don't have a speech. I'm just going to tell you what we've been through so that you can understand why this is an important bill. I should give you some background. My wife is a cancer patient. She was diagnosed as terminally ill in 1994. This is 30 years we've been doing this. In 2010, she got involved in a clinical trial that changed everything. She has breast cancer that had moved into the bone of her hips, her back, and her chest. And this clinical trial, in 3 months, she had a 30% response, and in 6 months, you couldn't see anything on a CAT scan. The problem was the treatment gave her what they call chemotherapy-induced anorexia. And when she had lost 32 pounds, which wouldn't hurt me any, but they said, that's it. The drug is killing you. I mean, you're starving to death. So when she went in for her last treatment, her nurse took me out in the hallway and said, there was a kid smoking a joint in the bathroom this morning. You might think about that. And it hadn't occurred to me at all. I mean, we tried everything to try to get it so that she could eat and keep anything down. She didn't even want to eat, much less be able to. She tried some, and within an hour, she was eating the biggest meal I'd seen her eat in over a year. And in 3 months, she put all the weight back on, stayed on the clinical trial for 5 years until it was approved by the FDA, and continues to this day. Well, she's been off treatment for 3 years now, but she continues to have issues with eating. She was on the drug for 11 years. And what it boils down to for us, and I hate to beat a dead horse, but it's about the money. For us, there are two elements to it, but the money, $350 to $400 a month, that's a car payment. So when we were faced with moving, we decided it's going to help us a lot if we just jump the border into Maine, where I can grow our own. And there are no regulations on us at all. I can grow 6 plants for each of us. I grow 6 a year, which is just about enough for her to get what she needs for the whole year. But the other aspect of it is the strain like they talked about. We know what she needs. I use the same strain every year. And I know what goes into that plant. We start them in the bathtub and they go out back. And all the fertilizers that I use are organic, everything. There are certain regulations we have to adhere to. We have to keep it out of sight. I have to make a reasonable effort to keep somebody under 21 out of the garden. It has to be locked up. And that's it. But it's what drove us out of the state. I couldn't afford it. We couldn't have, with everything that was going on financially, with all the medical bills. Her treatments were $32,000 every 3 weeks. And when you're faced with, maximum payments on everything, and the insurance companies kicking back what they won't pay for, it just was untenable. So really, that's all I've got. If you've got any questions, I'd be happy to answer.
Thank you, Ted. Any questions from the committee? Seeing none.
Thank you very
Thank
much.
you. Dr. Joe.
Thank you, Senator. For some, money can grow on trees, and today we're asking you to allow patients and caregivers to have that ability to grow their own medications to save their families and themselves money. People could spend hundreds, we've heard hundreds or even thousands of dollars a year for their medical costs, and if they're unable to afford those costs, they're just not getting it. Or they have to seek other alternatives that may be more harmful or have different side effects or not be what they really need. It doesn't just save the individual's money, it also saves states money. It's been shown in many studies that states that have had good, strong medical programs, robust medical programs, actually save Medicare and Medicaid costs from the state at the state level. I'm not saying cannabis is going to replace every medicine out there. It shouldn't, but for many people it can, and to have that ability to grow it. If we were allowed to grow, if insulin could grow on trees, it would be almost criminal not to allow it, even though insulin is a much more dangerous drug for people to take. The side effects are nowhere near what they are for many other drugs. We allow home brew of 200 gallons of beer or wine a year for 2 adults in a New Hampshire household. That's equivalent to about a 6-pack a day. There's no oversight. There's no program for it. We just allow it. And I'm just asking you to please at least do the same thing for something that has medical benefit that can save people that are hurting for money and hurting for their care to obtain what they really need. So I'd be happy to take any questions. And last thing, gardening, as many studies have shown, that gardening has a therapeutic effect, especially for people with depression, anxiety, and it's something that people are getting to. It's being recommended much more frequently for people who are able to have that ability. So there's more than one reason to do this. It isn't just about the money. It's about access, therapeutic effect, and just the right thing to do. And we already allow it for a much more harmful substance in New Hampshire, and no one bats an eye, and we've never had any problems with it. We don't see any problems with bootleggers selling their home brew or wine or anything. And I just ask you to please pass this. Thank you.
Any questions? Seeing none. Thank you. Paul Toomey. Paul, and then Matt Simon is next, and that is, I think, our last speaker.
Thank you. In 2013, I was the House Legal Counsel. When the first medical marijuana bill passed, I didn't take any part in that because when I took the job, I told Speaker Norelli that the one subject area that I couldn't give her any legal advice on at all was cannabis policy, because I'd spent my entire life seeing young people's lives get ruined by the needless criminalization of cannabis. And I just felt too strongly about it to give her any rational advice about it. So I stayed out of the bill. I did follow it very closely. In 2017 or 18, I was a member of the Legislative Commission to study cannabis. And on that commission, I was one of 2 members whose job it was to read all the scientific literature and all the medical literature, which I did then and which I've pretty much kept up with since that point in time. I myself am a medical cannabis patient. I started taking it because in the literature I read, I saw I have sleep apnea, and I'd read that it lessens the amount of incidents you have in a night. So I started taking it for that. I also have arthritis in all of my joints. I've had it since I was a kid. I played way too much football. 40 years ago, I was told I should replace both my knees. I've had a hip replacement. When I started taking the cannabis for the apnea, I couldn't open or close any of the fingers on this hand. My thumb was completely useless. I didn't take it for that, but after about 2 or 3 months, I started to realize I could use my hand again, which is, it's, if you're right-handed, it's kind of a helpful thing to have a right hand. I urge you to pass this bill, partially because of my experiences on it, but mostly because of my lifetime experience with people in poverty. My father was a disabled veteran. My mother was an immigrant. I had no medical care or access to medical care from the time I was 5 years old till I was like 30 years old. I never once saw a doctor or a dentist because we couldn't afford it. There are lots of people out there like that just simply can't afford the prices that the medical cannabis places have to charge, because some of these formulations are really odd and for different things. I take something that basically is the lowest amount of cannabis you could ever have, because the last thing in the world I want to do is be high on cannabis, which I've been about 7 million times in my life, but not in the last 40 years. And I just have absolutely no interest in being high. So I have to get something that has basically no ability to get you high. Well, there's not much of a general market for that. So you have to, basically it costs a lot. There are other things that are very potent that you can't get for cancers and things like that. And many people just simply have no access whatsoever to be able to afford it. I don't worry about money very much. I mean, I was a lawyer for 40 years. I made enough money. We put money aside. If I could stop giving it to my children, I wouldn't have a care in the world. But even when I go in and buy a little tiny bottle like this, and I only get one a month because I take 1 drop a night right before I go to bed, I go, because it's expensive. There are vast numbers of people who can't even come close to being to afford something like that. And I think the limited homegrown bill 1231 would give them the ability to access medicine so that they can live life without pain, so that they can eat food. There's nothing I can say about what Ted Wright just said. I mean, those are, some people can't move to Maine and some people can't afford the medical cannabis, and they live lives of misery, and you can stop that, and I urge you to do so. Thank you.
Thank you, Paul. Any questions? Seeing none. Matt, you're up.
Thank you again, Madam Chair. For the record, Matt Simon, Granite Leaf Cannabis. We strongly support this bill. As I mentioned before, Granite Leaf is a nonprofit dedicated to serving patients. And our leadership team feels very strongly that patients are not well served by felony penalties for home cultivation. We would very much like to be able to help patients with this and assist them. Our cultivation staff would love to teach classes if this becomes legal. Our dispensary staff would love to connect patients with seedlings. We'd love to be able to provide that service if it becomes legal. I will say on the cost issue, we've worked very hard to become more efficient, to lower prices. We have lowered prices. We've gone through one category at a time. In some cases, we've been able to automate processes. In some cases, it's been made possible as the program has grown. The first few years, it was only a few thousand patients we were serving, so there was no way for the dispensaries to essentially do a good job. We're up to around 15,000 patients, and that's made it possible for us to do a better job. And we did just reduce flower prices for the second time a few weeks ago. So you heard $350 for an ounce. Actually, our most premium ounce of flower is under $300 now. So if anybody hasn't checked our menu in a while, take a look. Prices are lower. We've reduced prices across every product category in the last 3 years. Unfortunately, the prices are still prohibitively expensive for some patients, as you've heard. So for that reason, and for the access reason, patients having to drive long distances to the only 7 locations, I've been advocating for home grow for 15 years. I'll keep doing it for as long as I need to until this passes. The handout I've given you is just a 2-pager, and every time another bill fails, I add another entry. It's almost 2 full pages now. I didn't have any gray hairs when we started. Now I have a lot of them. I really hope this will be the year. That's all I have. Happy to take any questions.
Any questions? Probably.
So, the point you just made about as the number of people have expanded, you have greater scales of economy. And I'm glad to see that the prices have dropped. If the prior bill that really, I think, would open up the prescribing, we'll call it prescribing, were, say, to take that 15,000 to 25,000 or 30,000, would those prices continue to come down?
That would enable us to further reduce prices. Senator, I'll tell you, we view these bills completely separately. For us, this is not a bottom line issue whatsoever. It's more of a philosophical issue.
And we've had this discussion many times, and I've
We
said
have.
many times that if the price stays in the range that it has been, 350 plus, I would think about home grow. But if it's going the other way, then I think about the problems that home grow, can produce in terms of, black market and things like that. So I'm glad to see progress is being made. I'm glad to see if the other bill passes, it might help the price progress.
Thank you, Senator. I think we can both agree there is very much still a robust illicit market for cannabis.
And always will be.
Allowing somebody to grow a few plants, I don't believe is a major contributor to that, but thank you.
Thank you, Matt. With that being said, very quickly, because we got 2 more bills.
Yes, just I really doubt we would see a big expansion. The great majority of providers really do not have a good solid feel to be able to suddenly start prescribing it. So I think if 1278 passes, I don't think we'll see a large expansion of the number of patients. I don't think so. Thanks.
You weren't on the list. Do you want to? Very.
Sorry, I'm the prime sponsor on the next bill. So.
Oh.
I apologize. I was getting.
You're ahead of me.
Yeah, sorry for jumping the gun a little bit. I appreciate the.
With that, I'm going to close the hearing. 12:31. All right, I will open the hearing on House Bill 1349 and recognize the prime sponsor, Representative Howard.
Thank you, Senator. Sorry for jumping the gun a little bit.
Absolutely
My name is
fine.
Representative Heath Howard. I represent the towns of Stratford and Barrington in Stratford District 4. I submitted HB 1349 for a few reasons, and I'll start with the first being the success of treatment of post-traumatic stress disorder. And we've had a number of states who have allowed for medicinal cannabis cards to be obtained by people who have post-traumatic stress disorder, which is a very specific type of anxiety. And we've seen a tremendous amount of success in especially veterans in their treatment of PTSD with medicinal cannabis. And the other factor of that kind of links into it is the fact that we have a number of people who are being prescribed benzodiazepines, which are they're pills like Xanax, and they can be highly addictive. And what we know is that in 2021, they had the highest death count on record thus far with 12,499. They don't have statistics for 2022 or 2023 from the National Institutes of Health. But those rising numbers of deaths have been a result of the combination of benzodiazepines with synthetic opiates like fentanyl. And we've seen a large surge in the combination of those two drugs to create a deadlier combination that is killing Granite Staters and Americans. So if we can allow people to have an alternative that hasn't caused any deaths and that does not have those addictive qualities that benzodiazepines have, then we can allow people to have greater control over their medical future. With that, I'm open to any questions. Thank you.
Senator Prentice.
Thank you, Senator Birdsall. And Representative, thank you for taking my question. So just to clarify on your testimony, are you suggesting that, well, you talked about the benzodiazepine, Xanax, Valium, whatever it might be, and then you talked about in combination with fentanyl. Are you talking about these two being prescribed together, or pill mills where they think they're getting a Xanax, but fentanyl's in it?
No. So what people are doing is they are taking these benzodiazepines as an enhancer. So essentially, it elevates the high that people experience when they're taking these opiates. So essentially, they are searching out these prescription drugs for the opportunity to have a better high. And if we can eliminate people even getting started down this route, because there are people who do just overdose on benzodiazepines on their own, and oftentimes that can lead into a greater addiction. And this would just kind of allow people to have another option that they could choose if they have had issues with opiates in the past, or are worried about being on benzodiazepines for another reason.
Okay, thank you.
Any other questions? Sian, thank you,
All right.
Representative. Representative Thomas.
Thank you for having me here again. Representative Wendy Thomas for the town of Merrimack. And I just wanted to give you some real life examples of using therapeutic cannabis specifically for anxiety. As I mentioned before, I was diagnosed with cancer, breast cancer in 2022, and I've had 3 massive operations, which has resulted in something called situational anxiety. And that's when before a test or procedure, it's beyond my control. I get anxiety. Normally, a physician would prescribe Valium or Ativan or something like that. I just take a small dose of cannabis, and when I say a small dose, I'm talking about 2.5 to 5 milligrams. That's all I need, and the effect. even though I'm a therapeutic cannabis patient, I do not like the sensation of being inebriated. The sensation that I'm looking for is just sort of a calming, like you've had a good glass of wine, sort of chill. So that's the value of this. Also because of the which is a little bit different because of the medical procedures I've gone through. I have PTSD from those, and so that's a different kind of anxiety. And so what I use for that is a vape pen, which gets the medicine into me a lot faster, and so I can handle that. Lastly, I used to work in a dispensary in Merrimack, and so I've worked with patients that have anxiety. And one of the concerns of anxiety is that sometimes sativa-leaning plants can sort of enhance anxiety. So that's where talking to one of the staff at the dispensary is very helpful. We know which plants to recommend, which ones don't. And again, because you're metabolizing this plant, sometimes a sativa is what you need. I worked with a vet who had very severe PTSD. He couldn't even go into a Walmart store because of the overhead lights. It would just trigger him. And so he wanted to try cannabis. He had heard about a specific strain that was sativa, and I said, you might not want to try that one, but he was adamant. He wanted to try it. He came back the next week and he said, "This has changed my life." He said he could go outside now. He could go to Walmart. He could resume things. So it is an incredibly effective medication for anxiety, and I urge you to support this bill. Thank you.
Thank you, Representative. Any questions? Seeing none. Jerry Kinnerk.
Okay, once again, for the record, Jerry Kinnerk, Chair of the Therapeutic Cannabis Medical Oversight Board. And HB 1349 does seek to add generalized anxiety disorder to the list of qualifying conditions for the therapeutic use of cannabis. The board did vote 7-1 to support this bill as it was written, and it passed the House on a voice vote. Anxiety disorder is a complicated disorder, and it's often treated with an integrated program of multiple modalities, including counseling, cognitive behavioral therapy, exercise, and medications. But even the use of FDA-approved medications for anxiety can be problematic with multiple side effects, and they're recommended generally as short-term interventions and not as long-term treatment. And Representative Howard just very nicely pointed out, in addition to just the bad side effects, some of the other problems that are used with inappropriate use, or what we see with inappropriate use. I also would have to say, likewise, his analogy or reference to PTSD as a type of anxiety is excellent. I didn't have that in my testimony, but I think that is a good experience in terms of understanding some of the background. Anecdotally, we know that cannabis can really relieve anxiety. In our patient survey, anxiety was listed by many of our patients as a symptom for which they use therapeutic cannabis. Oftentimes, they might have therapeutic cannabis for something else, maybe for pain, but they did find it helped them a lot in anxiety. And that's why we do these surveys, to get this data back. Then if we look at the science, studies have shown that CBD alone can help with social anxiety without the changes in cognition and sedation. So that actually makes it better than that glass of wine, because that glass of wine makes you feel better, but you really shouldn't go driving after that. Whereas CBD will not affect your driving. Low dose THC, or a combination of low THC and CBD, may reduce anxiety, but again, without producing any significant adverse effects. Now, the problem is the THC in high doses significantly can worsen or even cause anxiety. And in fact, where you will frequently see people coming into EWs with big problems of anxiety if they've suddenly taken a huge dose of THC and they're cannabis naive or don't know what they're doing. So you do need to use cannabis cautiously. So the board thinks that use of cannabis would be acceptable to treat anxiety. And this is a switch from what we did feel a few years ago, because we investigated this a few years ago and came out against it at that point. The standard approach in an ATC always is to start at a low dose and then titrate the dose upward slowly. Start low, go slow until you reach the desired effect without the undesirable effects of sedation or euphoria. That's one of the rare times when euphoria is a undesired effect. And they will know to keep the THC concentration low, because it's quite, again, we know that it's an important thing. Now, another good reason to pass this bill is that many people currently treat their anxiety with cannabis that they get on the unregulated black market, recreational cannabis market. But the use of unregulated and unlabeled cannabis will introduce the risk of a patient getting cannabis with a very high THC concentration, because in the recreational field, euphoria is the intended thing to have as opposed to a side effect. So the point is, they may get a very high THC, and it actually will make their anxiety worse. So we think it'd be far better and far safer for them to be certified to use therapeutic cannabis in order to be able to access tested, labeled, and contaminant-free cannabis under the guidance of an ATC. So it also could be viewed somewhat as a harms reduction maneuver in terms of its use. So we would urge passage of HB 1349. And I'll take any questions.
Any questions? Seeing none?
Okay, thank you very much.
Thank you. Dr. Joe? All right. That was our last speaker. Is there anyone here that would like to speak on 1349 but was not given the opportunity? With that, I will close the hearing on 1349. Okay, I'm going to open the hearing on House Bill 1581 and invite the prime sponsor, Representative Vale. Welcome.
Thank you. Good afternoon, and thank you, Chairwoman Birdsall. I come before your Senate and Health and Human Services Committee today. I am Suzanne Vale, representing Nashua Ward 3, and I'm presenting House Bill 1581. House Bill 1581 is an act relative to the cultivation locations for alternative treatment centers. And I'm just going to briefly tell you what this bill is about and how it would just be different than what we're doing right now. So, and I mean brief. 1581 aims to permit alternative treatment centers to utilize additional cultivation locations, which can be greenhouses. Using greenhouses for cultivation will reduce the electricity costs and decrease the cost to the alternative treatment centers when they are cultivating the raw product that they're going to use to make the products that they have in the dispensaries. So this is another way to reduce cost for the patients. Presently, the cannabis cultivation occurs in the enclosed grow house with artificial lighting and climate control systems that draw a huge amount of energy for heating and cooling. These processes of heating and cooling during the cultivation and product development is one of the central locations where a dispensary has like a discrete building that is one that supplies each ATC at their locations, even if there are multiple. So, but the bill only applies to cultivation locations. It does not include dispensaries, and it does not include a facility where you would be taking some of the cannabis and concentrating it, making it into the products that people use for medication. The bill only applies to cultivation. And it ensures regulatory compliance with existing departmental rules and with local regulations, which includes community engagement and local zoning compliance. Citizens will have a say about having a greenhouse in their town, just as outlined in 126X-6, Section 3, where community engagement involves solicitation of input from qualifying patients, caregivers, and residents that might be affected. So finally, just so that you know, efforts to educate legislators about the program and about the cultivation process all the way through, you know, what winds up going to the dispensary. There is an opportunity for legislators to visit and to get a tour and understand what the ins and outs are of the program. This is a program that's been evolving continuously since it was voted into law in 2013. And this is, again, just another way to reduce the cost and to help the ATCs with an agenda of my own, and I think well shared as we go and analyze the ways that New Hampshire could legalize. We want to make sure this program doesn't go away. There are people that depend on the program, and it is, and all of the things that you've heard today lead into why it is so complex. It is probably the most outstandingly detailed and regulated program in any state. And we should be very proud of what we've done to help people and to help them access care in the state of New Hampshire. Thank you.
Question? I do have one, but it might be better suited to one of the other speakers. But if we increase the product, based on what we've heard, where people are concerned because of the cost going into the treatment centers, based on what you're saying, if we increase the product, that would therefore reduce in the price of the. Okay. Sure.
And may I say a bit more? Thank you, Senator. If we increase the product, yes, but also the amount of energy that we need to decrease would really be a big part of that. So with the greenhouse, we would be spending far less energy to heat the product, keep it at a certain temperature, keep the air filtration, bring the temperature back down in order to make some of the products that they make, and to harvest the products that they are growing.
Where do they get the products from? Do they grow them themselves?
They do. It's from seeds. Everything is sourced from within each alternative treatment center. So there is no other products that are cannabis oriented or hemp oriented. Everything comes from this one growth center that they have that backs up the dispensary itself.
Thank you.
Last time today. Oh, yes. Last dance. For the record, Wendy Thomas, representative for the town of Merrimack. I would be remiss if I didn't tell you that I also sit on Science, Technology, and Energy in the House And this bill could also be considered a green initiative. We recently, no pun intended with the green. We recently toured the grow facility for Granite Leaf, and it is all inside. It's enclosed, and it uses a massive amount of electricity for the lighting, the heating, and the humidity. Allowing greenhouses would allow access to sunshine. It would also, if desired, they could use solar panels to offset some of this energy, which, to your point, could bring down cost. And when we're talking about cost, it's not going to bring it down, to $2 or anything like that, but it will bring it down. And then lastly, at some point in the state of New Hampshire, we will get recreational cannabis passed. And when that happens, we are going to have to put in place how to grow this product because it has to be grown in state. So this would prepare us for the eventuality of recreational cannabis as well. So thank you.
Thank you. Any questions from the committee? Seeing none. Jerry. Seen you a lot the last 2 days.
For the record, Jerry Kinner, Chair of Therapeutic Cannabis Medical Oversight Board, but in this one, I am not testifying on behalf of the board. I'm testifying on behalf of myself. I had actually not planned, so there's no written testimony. Actually, before we go any further, I want to make a comment. The increased product will not result in decreased cost by itself. And the reason for that, you all know that I'm a Democrat or was a Democrat, but I'm going to sound like a Republican for a minute. It has to do with the free market and elastic versus inelastic demand. Inelastic demand, decreased cost can drive increased demand, but you don't have an elastic market. You have an inelastic market because the demand is limited by how many patients are certified. You can't, if you decrease the cost, I remember many years ago, I wanted to get an iPhone, but it's too expensive. I wasn't going to do it. The price came down. I went and bought an iPhone. Well, that market increases when you could decrease the cost. Here, that can't happen. It is an inelastic market. And as a result, just increasing product alone will not decrease the cost. However, if you have increased patients, as we spoke about earlier, that certainly can do that. Okay, so in other words, I don't think just increasing the product will not decrease the cost by itself. However, it still will decrease cost, but there's a different mechanism. So allowing that second cultivation site, though, will allow more product to be made to meet future needs if the program grows. Again, I do not expect a big jump if we change the certification process at all, but there's been a gradual slow growth over the years, and that may very well continue. And with that in mind, we will need more product to be available, so that's going to help. A second thing it's going to do is, again, increase the product diversity, the availability of different strains, because you have more room to grow. You might be able to have different strains that might work better for certain patients. In some senses, that might slightly increase some of the use because a person may find another product that works a little bit better that they might have said, I'm certified, but this doesn't help me enough. So there'd be a slight bit there, but not that much because of, again, the inelastic market. And again, remember that the different strains are important because the different cannabinoid concentrations and terpene concentrations will have differing therapeutic effects. And so if they have more space and they can grow a different variety, that's going to be helpful. But the important part here, again, is the enclosed facilities piece. It is very expensive to run lots of high energy lights to be able to grow. Cannabis is a big plant. It's not a little thing. So it's going to use a lot of electricity, and this allowing greenhouse growing will really lessen that cost a great deal. So that should bring price down a little bit. So I think there's several things it's going to manage. Number one is, as the program slowly grows over the years, it will allow us to be able to meet the needs of the patients. It will improve our strain availability. It will decrease cost by decreasing the cost of production per unit. So that part will still go down. Now, so you may recall that I made that comment about we had a listening session a few years ago. And again, what were the big things that people complained about? Cost and accessibility and the strain availability. So this will again help to address cost and strain availability. So again, TCMOB did not take a position. I'm speaking on my own here, though I do believe that they probably would have agreed because these were our concerns for us. Any questions about my little economics lecture? I know it's hard to hear from a guy like me, but that's I couldn't resist. Oh, now I'm in trouble.
No, and I apologize for missing the
That's okay.
first part of the hearing, but just as I read this bill, it allows for additional cultivation locations, which may be a greenhouse. So I assume that is what makes it that it may be outdoors and not a greenhouse. Is that correct?
I don't think currently it has to be enclosed. The comment here about a greenhouse subject to rules adopted, that's still going to be enclosed.
It wouldn't have to be enclosed.
Well, a greenhouse is enclosed,
Yes.
so that you have security. It's not going to be just an open field. But a greenhouse though, is still visible. At this point, I think it has to be enclosed where you can't even see it. Mike Holt is on medical leave, so I don't have him here as my backup. But I think you have to be actually in a building at this point. Oh, actually, Matt Simon can answer that question for us better when it comes time. But the greenhouse would still be able to be secured and so on and so forth. But
Well, that was the other part of my question.
yeah.
If we authorize this, is it still going to have to comply with all the security?
Yes.
Okay. All right.
Yes.
Thank you. And apologize for missing the first part of the
No problem. I mean, from my point of view.
All right, seeing no more questions.
Well, thanks for your patience with me over the last 2 days. Thank you. It's actually a pleasure being in here.
Our last speaker, Matt Simon. And just an FYI, we will not be executing any of these bills today. We're going to exec some prior bills.
Thank you again. One more time for the record, Matt Simon, Granite Leaf Cannabis.
Did you talk to Deborah?
No problem. Take your time. I'm sorry. Again, for the record, Matt Simon, Granite Leaf Cannabis. We support this bill. As you've heard, patients have been complaining for years about the cost of therapeutic cannabis. One of many contributors to that over the years has been the fact that we are only allowed to grow indoors. That is the most expensive way by far to grow cannabis. And neighboring states have allowed outdoor and greenhouse cultivation pretty much all along. So this has been a major disadvantage to New Hampshire ATCs. This bill would enable us to use a greenhouse. The goal for us is not to grow more. We already have, as you heard, we hosted a tour, the first ever legislative tour of our production facility a couple weeks ago. And the legislators saw not only what we're doing, but we have a huge room that we could expand into. We have plenty of space to expand indoor cultivation if demand ever justifies that. What we want is to grow differently. We want to have at least some of our cultivation take place outside so that it can be much more energy efficient and so that we can make lower cost cannabis available to patients. To grow cannabis indoors, you basically have to simulate an entire outdoor growing season inside under high intensity lights. It costs a lot. So please pass the bill.
I just have a question. I know because I work at a nursery, so and they have a greenhouse, which they still have to heat. Wouldn't you have to heat the greenhouse, especially in the winter? So what makes it so much less expensive?
Well, I am not an expert on greenhouse cultivation or really any other aspect of cannabis production. So I'm pretty good at trimming buds. That's the one thing they let me do, which I've done for a few hours twice in the 3 years I worked for Granite Leaf. They usually have me busy doing other things, but I could probably get you an answer to that, but I don't know. It may be that the greenhouse would only be used part of the year. I have no idea how that might work, but you can definitely.
Yeah, I can answer that for you. I have to get down to your ball.
Well, let him finish.
All I know is our team and people in the industry say that greenhouse cultivation enables cheaper production. So
Thank you, Matt. Any
Thank you.
questions? Nope. Okay. Jerry, one last time.
Sure. Yeah, well, I do a lot of greenhouse growing. And in fact, in May, I'm giving a lecture for Alviette, New Hampshire about greenhouse growing. I don't mean of cannabis, vegetables. But here's the point. By mid-February, I have to restart up my ventilation system on my greenhouse because it will get over 100 degrees in February. And mine is just a simple double wall poly greenhouse, not the fancy polycarbonate that actually has much better insulation. That's how intense it can be. So sort of between about mid-November or early November until mid-February, which actually we call in gardening the Persephone period, down in the underworld. She comes back up, and that's actually the period of time where the sun is so intense. You've got to actually ventilate to keep it from getting too hot. So, which costs not that much money. Heating can cost some money, but it doesn't take a lot. And again, you have to heat a building all the time. And I don't have to use air conditioning inside the greenhouse. I can just use ventilation. But you do have to create this when you're creating a product like this. You have to really be cautious about a number of parameters of humidity and temperature and so on, but that can be done cheaper in a greenhouse than inside. Yeah, it's amazing how hot it gets in February.
They won't let us in the greenhouse in February. Thank you.
It's just vegetables.
All right, that is our last speaker on House Bill 1581. I will close the hearing. And I think we should recess for 10 minutes so we can round everyone up. So we will meet back here at 25 after for exec. Correct, Amanda.
Good to see you, Jerry.
They leave.
So who's rounding them up?
All those in favor say aye.
Yes.
Opposed? Okay, so. All right, I'm gonna do this in numerical order. 11-1042, repealing the requirement for each pharmacy. Yeah. If, from what I remember, it was well-intentioned, but
Not being utilized.
yeah,
So they're not using the data, they're not running the program. That's
Right.
what Representative Mertz testimony.
yeah. And there was, there were only two people that opposed the bill, Janet Lucas and Daniel Richardson. Most everyone else was in favor of it, so,
I'll move on to pass.
Second.
all right. Any discussion? All right, this is true. All those in favor of ought to pass, say aye.
Aye.
Opposed?
Move consent.
Second.
All those in favor of consent, say aye.
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 Opposed? Senator Abar, do you want to take this out? I'll do it. I'll do it. Never mind. It's going to take me longer to write things out than it is to do this. All right. 11:55.
I'm sorry, you said 11:55?
Yeah, that was relative to insurance coverage for living organ donors.
Move on to pass.
I'll second. The only person that was neutral on it was Michelle Heaton. Everyone else was in favor of it. This basically, as Representative Cambrell said, it's a bipartisan bill to protect living organ donors from losing their life insurance or facing rate hikes. Insurance carrier policies about living organ donors are both written and unwritten. So,
And
even though although Michelle Heaton signed in as neutral at the hearing, we did get an email today with a letter from Commissioner Betancourt in support.
oh, okay. Oh, good. Okay. I thought you were gonna say.
my motion then.
No, did you? Jeez, you
Did
all
you
right?
just hear that?
No, I saw I saw your face. You okay? Is that your neck?
Yeah. And I get a ring in my ear when that happens.
Oof.
I think it's because I'm sitting
Gene,
next
I know.
to you.
No. This is like dealing with pre-existing conditions and like just protecting these folks, getting the same treatment.
Okay.
Yeah, I'm good.
All right.
You already covered it.
All those in favor ought to pass, say aye.
Aye.
Opposed?
Consent?
I'll second. All those in favor of consent, say aye.
Aye.
Opposed? Senator Abar will take it out.
if we want to put the commission to study environmentally triggered chronic illnesses on the consent calendar, we could reconsider our motion.
We voted on that today.
No, you're
I'm
looking,
thinking of a different one. I apologize.
right, the one we ought to pass today.
Oh, yeah. This was not.
This was the commission to study housing for the disabled. Do we want to put that on consent? Because we can reconsider it all. And why don't we do that at last? Okay.
Will that be okay because you weren't here? All right, you're the ace.
1190, relative to
here?
adopting the
Madam
interstate social work licensure
Motion
pact.
not to pass?
Second.
Your microphone was off. That's what I was telling you. Oh, I know. I put it on because I was going to make a motion.
Sorry, we're all good over here, Senator. We're fine.
So motion
We're
not to
doing
pass,
okay.
seconded by Senator Bradley.
Did you?
Yes.
Okay.
I don't even know what they
I'm beginning to question whether I do. Okay. Okay, the motion is ought to pass. All those in favor, any discussion?
Love it. No, I'll take it.
All those in favor of ought to pass, say aye.
Aye.
Opposed?
Consent?
Second. All those in favor of consent, say aye.
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 Opposed? Senator Prentice, would you like to take this out?
You bet.
Yep. Oh, you know what? I had thought about 1028, but we don't have the amendment yet. So, I'll talk about that after. Let's just do this one.
What's the amendment?
It's a commission.
Oh, that's right. I'm sorry?
Yeah. 1615, relative to the autism registry. This was when they testified that they initially put the registry in for some of the data, but now DOE has more accurate data than the registry. So they're trying to get rid of they want to get rid of the registry and just use the DOE data
Motion ought to
on
pass.
autism. Motion is ought to pass. I'll second for discussion. No discussion? Okay. All those in favor of ought to pass, say aye.
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 Opposed?
Consent?
Consent.
Second.
Okay.
Can I take it out?
You already have one.
So? No.
No.
Come on.
Senator Prentice, Senator Whitley, will you take this out? Oh, sorry. All those in favor of consent, say aye.
Aye.
Opposed? Senator Whitley, would you like to get the next one? Actually, no, I get that one.
Oh, you voted on one while I was gone.
Yes.
Got it. But I'm here now.
Right, and Kevin was gone, so we'll reconsider that one.
Gonna do 1213.
Oh. Which one's 1213?
The one we heard yesterday, immunization requirements for child care agencies.
I didn't have that on my list.
We talked about.
Okay. 1213.
The one you had
No,
to
I
wrap
know,
my
I-
knuckles.
Oh, here it is.
Yeah. Interim study.
Second.
Do I hear a motion?
Interim study.
Study.
And I second it.
Okay.
I thirded it.
Any discussion? All those in favor of interim study on House Bill 1213, say aye.
Aye.
Opposed? Consent?
Consent. Second.
All those in favor of consent, say aye.
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 Opposed? Okay. Right,
Is that what you
and
need, Cam?
do you want to take this one out?
No.
Okay.
I wanted the other one.
I'll take.
It's on consent, Senator Bradley, you could take it if you wanted to.
No,
No.
Senator Prentice. All right, the one we just did today, that was 1168.
I'll move that we reconsider our final vote on 1168.
Can I second that if I wasn't here? Okay.
All right, all those who want to reconsider the ought to pass, just ought to pass as amended or ought to pass?
No,
So it was ought to pass as amended.
amended.
So I've asked to reconsider that.
Okay, yeah.
Okay. As amended, okay. All those in favor of reconsideration, say aye.
Aye.
Opposed? Okay.
So
Now,
just so that Kevin and Becky know, there was a
Yeah.
committee amendment to extend the date for a year and require an interim.
right, so it was originally wanted a minimum of 6 meetings with a final report this November, which we thought was a little bit short. So it's 11/1/25 with an interim report for 11/1/24.
Make a motion not to pass?
The motion of ought to pass as amended was already made and seconded. So you're just voting on the motion of ought to pass as amended
Including the committee amendment.
with the committee amendment with all 5 of you here.
Okay, yep. All right, all those in favor of ought to pass as amended, say aye.
Aye.
Opposed?
Consent.
Second. All those in favor of consent, say aye.
Aye.
Opposed? All right, Kevin will take this out. I'm sorry, Senator Azar will take this out.
Me too.
And just an FYI, as we talked about a little bit before, 1028, the definition of mental illness, the prime sponsor has agreed to do a study committee on this. So when we get that, we'll go ahead and exec that too. Anything else you want to talk about? Seeing none. I move
Motion to move out of exec?
second. All those in favor say aye.
Aye.
Opposed? We can go back to your committees.
Oh,